focus on topics related to healthcare disparities and what to do about it. So let's dive in. Today, our topic is weathering erosion by racism. And this is a collaboration with the American Medical Association. We're really excited about that. So let's talk a little bit about weathering for those of you who may not be familiar. The definition for the weathering hypothesis states that it's chronic exposure to social and economic disadvantage that leads to accelerated decline in physical health and outcomes, and could partially explain racial disparities in a wide array of health conditions. So that's what we're going to talk about today. The American Medical Association and their Center for Health Equity have really leaned in on this topic lately. And as a matter of fact, they issued a press release recently, which focused on racism as a public health threat. So systemic racism, cultural racism, and interpersonal racism. And this policy that they issued is really a best practices for healthcare institutions, physician practices, and academic and medical centers to really address and mitigate the effects of racism on patients, providers, international medical graduates, and populations. And, you know, as we've been talking about for the past few months, this is important work so that we're really thrilled to be able to talk about some of this today and solutions. And also we're excited that the medical organization like the American Medical Association is really leaning in to target this as well. So let's get started. I want to introduce our panelists today. I'm really thrilled that they're here to talk more about this subject. I think you all are going to find that it's critical, it's important, and there's a lot to learn. So I'll start with Dr. Denise Serbinson. She has an intersectional career in public health and academic psychiatry. She's the president of the Institute of Women and Ethnic Studies, a community-based translational public health institute in New Orleans. She's also the chair of psychiatry at Charles R. Drew University. And Dr. Serbinson has held clinical professorships in the departments of psychiatry at Columbia University and Tulane University. She is a graduate of NYU School of Medicine, and she also received a Master's of Public Health and Population Studies and Family Planning from Tulane University School of Public Health. She completed her residency in psychiatry at the University of California, San Francisco, and is certified by the American Board of Psychiatry and Neurology. She's a fellow of the American Psychiatry Association. In 2018, she received the Award for Excellence in Service and Advocacy, prior to which she received the Jean Spurlock Minority Award. Dr. Serbinson, say hello. Thank you so much for joining us. We really appreciate you being here.
It is an honor to be here. Thank you so much.
Awesome. Next, we have Dr. Karen Glover. Dr. Glover is the attending psychiatrist at the Adult Outpatient Psychiatry Department at Montefiore Health System. She's a former vice president of the Black Psychiatrists of Greater New York and Associates. Dr. Glover has spent her greater part of her adult life following her interest in science, health, and improving life for the underserved. Currently, she's the assistant professor of psychiatry at the Albert Einstein College of Medicine. Dr. Glover teaches psychopharmacology and aspects of psychotherapy to internal medicine and family medicine residents. She's an attending psychiatrist in the Adult Outpatient Psychiatry Department at Montefiore. Dr. Glover has authored a peer-reviewed article on mental disorders in primary care, contributed to a textbook on psychiatric treatment in primary care, and has extensive experience in psychopharmacology and substance disorder treatment. Dr. Glover, thank you so much for joining us.
Thank you for inviting me. I'm really happy to be here with you guys.
And we also have Dr. Keith Ferdinand. He's the professor of medicine at the Gerald Berenstein Chair in Preventive Cardiology at the Tulane School of Medicine. Dr. Ferdinand began his medical career with a BA in biology from the University of New Orleans. He went on to earn his medical degree from Howard University College of Medicine in Washington, D.C., an internship at the U.S. Public Health Hospital in New Orleans, an internal medicine residency and cardiology fellowship at LSU Medical Center, and a cardiology fellowship at Howard University Hospital. After years of doing clinical work, research, and teaching at Xavier University, LSU, Baylor College of Medicine, and Emory, Dr. Ferdinand returned to New Orleans as a professor of clinical medicine at Tulane University Heart and Vascular Institute. Dr. Ferdinand has been heavily involved in many national organizations concerned with public health, including the Association of Black Cardiologists, of which he was the former chair and Chief Science Officer, the American Society of Hypertension, of which he is a board member, and the Healthy Heart Community Prevention Program, a cardiovascular risk program targeting African American and other high-risk organizations. Dr. Ferdinand, thank you so much and welcome to Black Health Now.
My great pleasure to be here.
Okay, so let's dive right into this topic. We've got a lot to talk about. So starting with you, Dr. Ferdinand, talk to us a little bit about how weathering has impacted the cardiovascular health of Black Americans.
Well, cardiovascular health is related to the conventional risk factors: hypertension, high cholesterol, diabetes, smoking, obesity, physical inactivity. But beyond that, we have the social determinants of health, where people live, work, and play. Living in a zip code where there's pollutants in the air, the water is not clear, the person is under environmental stress, has a great impact on cardiovascular risk. We can actually do geo mapping or zip code mapping, where we can tell not only who did you vote for in the presidential election, but what is your health? What is the chances of you having hypertension and heart disease? A combination of factors then impacts on a person's cardiovascular health, not only the traditional risk factors, but the social determinants of health.
Okay. And there's been a lot of discussion about the social determinants of health. Is that why Black Americans are at such higher risk for these cardiovascular conditions? And would that explain the difference in why Black Americans suffer disproportionately and Africans, for example, don't?
Well, we think genetics may be part of the problem, but it's only a small part of the problem. What you have in an African American population, and we see this in other parts of the African diaspora, are the results of structural racism, how people are treated from early in childhood throughout their development, the barriers put to having healthy foods available, the so-called food desert approach, the intense marketing that's done in the Black community. There have been several studies that show fast foods and cigarettes are marketed heavily in minority communities. Not having access to insurance or having insurance which is poor, not having an identifiable source of primary care. And then even with an insurance and primary care, and I practice here in New Orleans, many patients don't know their primary care provider or have such a poor relationship with them that when I ask who is your primary care doc, they don't even remember their name. So there's bias even within the healthcare delivery system, where clinicians don't take the same time and effort with their Black patients as they may do with their majority patients. These are so many different things. I call it a gumbo-like mixture of psychosocial, environmental, and socioeconomic stressors.
Mm-hmm. I'm wondering, I just want to follow up a little bit on what you just said, Dr. Ferdinand. Oftentimes physicians aren't taking as much time. Patients don't necessarily know who their primary care providers are. Do you think that explains some of it then, with this kind of disconnect that's happening between patients and physicians often? Is it that physicians may perceive then that patients aren't as engaged in their care, or on the flip side of it, patients may feel like, well, my physician's not really engaged and invested in me. So is that partly responsible potentially for this disconnect?
It's very complex. Physicians actually have biases, implicit bias. They may not even be aware of this. And there have been some studies using videos. Well, they give a script to an actor and have that actor give certain symptoms related to heart disease. And then they'll show the same script with another actor who happens to be Black. Same script, same presentation. And the physicians tend to treat the white person who's running that same script differently than they do the Black. And this has been shown in multiple studies. I don't think our patients are just ignorant and backwards. There's real bias in the healthcare system. The AMA is doing a wonderful job, but if you go back to the turn of the century, the AMA did not want Black doctors. And there's a legacy within conventional healthcare structural medicine of bias and outright discrimination. And it goes way beyond Tuskegee. That's kind of a touch point for many Black patients. But even if we take Tuskegee out of the picture, there were hospitals where you had the Black hospital, the white hospital, the Black ward, the white ward. There were doctors who didn't want Black patients at all or would only see them on certain days, or Medicaid patients on one day and, quote, good private paying patients on another day. These sorts of biases are kind of cooked into medicine And many times we as physicians don't want to face the music that it's real.
Okay. All right. So I want to go back to weathering for a minute. Thank you, Dr. Ferdinand. You know, because weathering impacts, as you just described, physical health, right, in a negative way, but also mental health. So I want to direct this question at Drs. Serbinson and Glover. How does weathering impact the mental health of Black Americans? I'll start with you, Dr. Glover.
So I think often we in psychiatry have been thinking about how toxic it can be to be exposed to discrimination in multiple domains of your life. You wake up in the morning, you check the news, you see that a Black person, innocent as can be, was killed quite graphically, right? And with impunity, right? Like that this person who took this other person's life may work for the state and may actually get away with taking somebody's life just because they're Black. So that may be the beginning of the day. And then you walk to your car, you get in the car, and then maybe somebody stops you. A cop may say, "Is that your car, this late model Benz?" Right? And so it's this everyday kind of grinding down of one's own self-esteem and one's own sense of righteousness to be and do as you please, right? And then you get to work and a security guard goes like, "Is this your office? Because you don't look familiar to us." So experiencing discrimination in multiple domains of your life has been shown for Black people to, in many ways, result in blood pressure that's 10 millimeters of mercury higher than their white counterparts who haven't experienced such discrimination. So there's that, right? Just physical health. And then for mental health, there's recognizing that you're being treated unfairly and knowing that for every Black person who's killed by police or has this terrible interaction with police, often there's an increase in depressive symptoms among the Black residents in the same area as where that killing took place. So they may not have outright depression, but there may be an increase in depressive symptoms for at least 90 days after that kind of tragic event happens. So when we think in terms of those events happening back to back to back and being portrayed in the media back to back to back, we're talking about Black people suffering mood-wise for months and months on end. And that's just the beginning.
Yeah. Dr. Serbinson, do you have something to add to that?
Yes, I think two other doctors so eloquently talked about the socially toxic environment in which many of us live, regardless of socioeconomic studies. I think some of the idea of weathering that you referenced, Arlene Geronimus, who was the public health demographer, she looked at Black women and their birth outcomes and found that it was not just poverty, as we oftentimes say, was the biggest factor. It was also the combination of racism. And I like to use the word racism versus biases and disparities. Sometimes we just have to say it because we really, in our gut, knows what that is. And it's just as Dr. Glover said, the continual microaggressions throughout our lives, the adversities that we find ourselves in. Even from New Orleans, I must say, if a disaster happens, the inequities that happen in terms of our recovery, and eventually getting such negative social feedback about who you are, your own humanity. For some of us, we even begin to internalize racism itself and begin to think that we are lesser than. And so in addition to the interpersonal and institutional levels of racism, there's a lot that happens internally to us. And we are going to, it is I would say the continuum of how ultimately our health, our mental health, and our physical health, which are so intertwined, we're the ones who differentiate them out. It's all the same biology. And so, yes, I think that racism and the impact on our allostatic loads and then hence the wear and tear and weathering is very deleterious to our health.
Yeah. So just kind of continuing on with the thought around the stressors and mental health, traditionally in the Black community, there has been stigma though around care seeking and looking to professionals to help navigate these. And we do know that in the Black community, traditionally, there is a sense of community, and often Black Americans have been able to rely and lean on one another to get through these kind of difficult microaggressions that happen on a day in and day out basis associated with racism. But do you think that now in this time where there are so many added stressors, because there's so much open discussion around seeking care for mental illnesses and depressive states, do you think that that's changing and that Black Americans are recognizing that there's help out there and that they should reach out for that?
I'll say for my part, I think it depends on the demographic, right? Because Black people are not a monolith, as we all know. So I think among younger people, there's lots more discussion and lots more openness to seeking mental health. The movements by Taraji Henson, right? The Boris Lawrence Johnson Foundation to help fund mental health help for Black Americans, I think has gone a long way to shift the discussion around help seeking. I think Beyonce and Jay-Z and their sort of open discussions around Jay-Z seeking therapy went a long way towards letting Black men know that it's okay. And then the movements around using social media to leverage messages around mental health, right? We're talking about therapyforblackgirls.com, other apps like Liberate app that are designed and tailored to focus and welcome Black people to the therapy space. Beam community out there in LA, there's a lot of movements, I think. And I'll add that I was on a webinar with folks from the Church of God in Christ. And there was a church mother, easily a woman in her 70s. And she was like, I can't tell you enough how much therapy can be helpful to our people. I'm the first person to recommend that somebody seek pastoral counseling and psychotherapy from a licensed professional. So I do think things are changing.
Okay. Dr. Serbinson, what about you?
Yeah, certainly some of the stigma comes from our own attitudes, but similar to what Dr. Ferdinand did when he went back into some of the history of the racism in healthcare in America. Part of why we do not like to seek mental health care was that since slavery, mental health in the Black population has been criminalized. If you look at in New Orleans, people were sent to the jail, and this is not just recently. This goes back all the way to the 1800s. So if we put the two constructs together, that if you have a mental condition, you also some kind of a criminal, and that's why you're insane. I think the population who gets that message is going to not want to think that they have mental health conditions. So a lot of these resistances in us as a population goes back to the enslavement histories and oppression and all along. And I think we need to tease that out so that we can recognize why it exists and so that we can change the behavior. But it just didn't start because
Dr. Serbinson, I can give you a very, very vivid example. In 1856, a Tulane physician, because it's an old medical institution, coined a disease called drapetomania. And drapetomania meant that a slave kept running away. And he actually had a prescribed therapy for drapetomania, and it was whipping the hell out of them. I'm not creating this. Those of you who are Google enhanced, look it up. Drapetomania.
He was president of the Medical Society of Louisiana at the time he delivered this. Yeah, so there are reasons.
And could I also add that there is historically a tendency to misdiagnose Black people when they do show up for care. So Black people can, as Dr. Ferdinand said, show up with a certain set of symptoms. Somehow, only one set of symptoms gets listened to, and the other set of symptoms, usually the ones around mood, the ones around depression, those get ignored. And so I think it's important to keep in mind that sometimes, even when Black people do their best to show up, be vulnerable, they are not always greeted and viewed and treated like full humans.
Yeah, that's very telling. That's a powerful statement. And drapetomania, again, just to go back to that for a moment, just so people really like can get the full weight of what you just said. Running away from slavery was labeled an illness, a mental illness, and that was punished.
Correct.
By whipping
Correct.
and other things. Right. Okay. Yeah. That's very telling. So one of the things that I wanted to just kind of go back to as well, mindfulness. Dr. Glover, I know you have a lot of experience with that and you've used that in your practice. So I just wanted to double click on that a little bit because I thought that was interesting. And as we think about kind of, what do we do, right? There's a lot of kind of odds stacked against Black Americans when we think about social determinants. I love Dr. Serbinson's phrase she used, social toxicities, discriminatory factors in life, so mindfulness. Can you talk a little bit about that and how that's helped patients in your practice?
Sure. So I think, right, the most I can see patients is usually once a week, maybe sometimes once a month, given how busy our clinic is. And so in between visits, I often advocate for my patients to engage in lots of different kinds of activities for self-care. One of them is mindfulness, this practice of spending 5, 10 minutes, up to 30 minutes, if you have the time and the space and the quiet, to really just get in touch with your body. And the idea is that by routinely checking in with yourself, you get a handle, you get a sense of when you're feeling overwhelmed before it happens publicly or before it happens when you're giving a presentation at work, right? The idea is that often we walk around with our feelings in a box so that we can function at work, we can drive and pay attention to the road, we can pay attention to our loved ones. What we don't want to happen is for those feelings to jump out of the box when we're not ready. And when it's inconvenient or when we are at risk in any way. So mindfulness is a way to learn how to be present, to learn how to check in with yourself so that you can essentially take care of your mental health.
Fascinating. I think that's it sounds like something that definitely can help a lot. So when we think about kind of weathering, going back to this topic, right, the topic of this conversation, the physical impacts, right? Dr. Ferdinand talked about that, hypertension, cardiovascular disease. We talked about the mental impacts. Where do we start as we try to think about impacting change for, people who are going through these conditions, whether they be manifesting themselves physically or mentally? Well, where do we start?
Let me give some practical tips. Hypertension is a manifestation of stress. It's a manifestation of high sodium diet intake, low potassium. So that's the inverse of eating a lot of sodium, is not having enough fresh fruits and vegetables. Physical inactivity, so the inverse of that is being more physically active. And you don't have to run a 4.340 like an NFL player. Just walking, a brisk walk, the guidelines are a total of 150 minutes a week. So that's 30 to 40 minutes most days of the week. Relaxation response, which could be quiet meditation, mindfulness, rhythmic breathing. These things have been known for centuries to decrease what we call the catecholamines. That's the adrenaline, the hormones that are coursing through the body, and medications. We've already done the placebo-controlled trials where you take one group of people who have hypertension and you just watch them or give them a sugar pill or placebo, another group of patients, and you give antihypertensive medications. Those persons who take medications and adhere to medicines not only lower the so-called number on the blood pressure, but they decrease heart attacks, strokes, chronic kidney disease, heart failure, and death. So we don't need to reproduce the placebo-controlled trials, but we can add undergirth of the pharmacotherapy is what I call therapeutic lifestyle changes. And walking does wonderful jobs, not just for blood pressure, but it does a wonderful job for decreasing a lot of the psychosocial stress that all of us are exposed to.
That's a great prescription because you're absolutely right. Walking and getting some sort of physical exercise. And we talked about, social determinants. I mean, that's something that you probably counsel your patients on, Dr. Ferdinand, that practically anybody can participate in, no matter where you live and what's happening, right?
Let me use this opportunity to alert people what's going on in the pandemic. it's now been shown that African Americans have more infections, more hospitalizations, and more death. But the other impact is the intense psychosocial stress that many families are living under. I often would do virtual visits, and the virtual visit lasts anywhere from 30 to 45 minutes. In some patients, most of that time is spent talking about or lamenting a family member who is sick or dead. One gentleman spent his whole time telling me about his daughter who had been on a ventilator at Tulane Hospital. He hasn't seen her in a month. So we talk about the deaths, and death is certainly bad, but there's a real psychosocial stress, a real impact on the Black community of living in this pandemic.
I want to go back to that, the COVID and the time that we're living in. So, one of the things that I wanted to understand more from you in particular, Dr. Ferdinand, was whether or not this kind of gap in treatment and incidence is narrowing, if you've seen any indication of that with all the treatments and all the discussions that we've had broadly around, taking care of ourselves. But then COVID happened, right? And, that's added stressors for everybody, including Black Americans. And, there's a physical manifestation of the increased incidence, but then there's the stressors that you just talked about. Do you, and this is a question for all, anticipate that because of this, what will be the implications? Do you think that you're going to be busier, Dr. Ferdinand, because people are inside and there's a lot of stressors, and that Dr. Glover and Serbinson, you're going to be busier too, because people are just trying to cope with this, in addition to just being sicker often because of COVID and kind of being on lockdown and all the stress associated with knowing and having loved ones who are affected?
Well, I'm gonna give a short answer and let my colleagues take it from there. I don't want to be dismal, but I also want to be a realist. These disparities, the white-Black death gap, have been present for years. You can go to national data, national health statistics. You can go to cardiovascular data on the rates of blood pressure, chronic kidney disease. People on dialysis, 3 times more common African Americans than the general population. They're not going to disappear overnight. And I have absolutely no hope that they are going to go away unless we change what I call structural racism. I don't care about the bad tweets or somebody with the bad Facebook post or someone calling me out of my name. I really don't care. If we don't change the structures in terms of education, housing, available good food sources, having an identifiable source of primary care, referral to specialists like these wonderful lady psychiatrists who are speaking today, then we're not going to change a doggone thing. In fact, I'm going to go really take it out there. I'm going to go old school on you. Some of the worst racists were very nice to Black people.
Dr. Ferdinand, how do we come back from that? How do we come back from that? I just also, want to mention in terms the recent studies that have shown that 1 in 5 survivor of COVID is now suffering from anxiety and depressive disorders. I would love to, I did not see the racial breakdown on that. And I know a lot of, it's easy to say, well, we had all that inflammatory process from the virus itself, but there was also a death encounter. We're right back to the early years of HIV disease, where if you got the diagnosis, you thought you're going to die. And for many people, having to mentally deal with, I have COVID, or even the anxieties about I could get it. And so I think we're going to have a lot of work to do. We are already, our population overrepresented. Dr. Ferdinand, I didn't believe some data that I heard, and you sent me the evidence that it's the 3rd now leading cause of death since January. COVID is the 3rd leading cause of death in Black people. I just couldn't believe it. I had to ask for evidence. So I think we're going to have a lot of anxiety and depression. And for some of us, when we feel so overwhelmed, we turn to substances or we get very aggressive. So I think us in mental health, Black people, we're going to have to really push, one, to get our population, our people to know we need support, but also the systems that need to give us access to more mental health services.
If I could also add that one good thing that we're experiencing, because we're all remote for the most part, is that our no-show rates have changed dramatically. So maybe we went from having a 20 to 30% no-show rate. Now we've got like 110% show rate. That it's, when I reach out to my patients, they're in their bed and they're like, well, look, I wasn't going to miss this. All I have to do is open up my phone, to see my psychiatrist now. So I think in some ways there's greater engagement among our patients. Getting them to come back when it's safe will probably be another discussion as well. We may not, who knows when we'll go back to seeing patients in person in the volume that we had previously.
Well, I certainly think telemedicine has been a great boon, but as you know, there is a digital gap, especially older members of our community have a lot of difficulty with the smartphone. Some people have smartphones and don't really know how to use them other than to call the grandkids. Then you have people who have wireless rates at which they use all their rates up and they can't really do any more visual virtual visits, and they end up just using it as a regular telephone. One of the clinical pearls that I suggest everyone do is, if you have blood tests or if you have blood pressure numbers or you've had an x-ray, get the result or make your physician or nurse practitioner articulate what that result is. I have seen so many patients, when I get their old records, they have chronic kidney disease, diabetes, high cholesterol, their blood pressures are 150 over 100. And you know what they've been told? It's all right. Your blood pressure, oh, that's just your blood pressure. Oh, your kidneys, it's a little bad. Nobody takes the time to go through that record with the patient and give them the specific number for the glucose, the glomerular filtration rate. What did the electrocardiogram show? What was the ejection fraction? And I see this every day, and it's very distressing. Some doctors are hiding behind HIPAA. They use HIPAA as a blunt tool for not talking to patients and their families. And I don't want to curse on an open webcast, but I get really upset when I hear that kind of thing, because what they're doing is they're saying, I can't talk to your daughter because of HIPAA. No, you don't want to take the time to talk to that lady's daughter.
Yeah. Well, that raises another important point too. We often talk as part of Black Health Now about the importance of having advocates for your loved ones, and having somebody there who can, especially for older loved ones, like who can ask the right questions, who can engage healthcare professionals to make sure that the patient understands, that the family and the caregiver really understands. I think that that's really critical too. But kind of going back to weathering for a moment, I have a question here. Can the expectation then of negative outcomes based on so much lived experience around racism lead to weathering? Like, we talked about kind of the stressors leading to weather, the expectation then that your care is not going to be as good, the expectation that you're going to be discriminated against more, and that also can lead to the weathering effects that we talked about.
Well, in the 60s, I'm old enough to remember the popular music was just the opposite. Nothing can stop us now. People get ready. There was just so much music that said, I don't care if they're sicking dogs and putting hose pipes on us, we're going to do better. I think we need to embrace that spirit. It's kept us going for 400 years. That, yeah, things are bad. And I know I sound very harsh at times, but I'm trying to be a realist. We can overcome.
Okay. Dr. Glover, were you going to add to that?
Oh, yeah, I was just going to say that two of the researchers whose work I admire a lot are Nancy Krieger at Harvard and David Williams, both at Harvard. And Dr. Williams was on Ezra Klein's podcast, and he talked about the anticipation of discrimination, that when a Black person, male or female, or a Latina, right, goes for an interview, if they are anticipating a bias treatment or discrimination, their blood pressure goes higher, right? And so repeatedly knowing that in the process of trying to advance your life, in the process of trying to just live and be human, right, anticipating discrimination is also toxic. but knowing that you have to, because part of our socialization as children is to hear the wisdom from our elders about how to navigate bias and how to navigate discrimination. So you can't turn that off, because part of that is intelligence that's helping guide you through difficult situations. So in some ways, there's an exchange, I think, in terms of the intellectual development Black and Latinx people have for navigating white supremacy, but also what we give up in terms of anticipating that difficulty as well. And the toll it takes on our cardiovascular health, ultimately.
Yeah, that's interesting. Dr. Serbinson, did you want to add anything to that?
Yeah, I was going to say the chronic wear and tear, and it's found, as we talk about resilience, sometimes having to adapt too much eventually begins to load the body. And so, it is that balance between mild paranoia, as I say, and healthy realism. And I think what I recommend with myself and the people I know, if you find yourself going too far in one direction, you need to pull yourself back. But we have to be able to swing between those two poles. I think that is how we're here. This is what our ancestors did, and what, unfortunately, we continue to have to do.
Yeah, it definitely continues. And, Dr. Ferdinand, you've all talked about kind of the built-in bias in the system and, the structural racism that exists, even when oftentimes they're sitting in front of their care provider. What is the medical community doing?
Well, I think self-monitored blood pressure, and we're dealing with hypertension as perhaps one of the main issues, along with psychiatric and mental stress. But self-monitored blood pressure is important. There's a website called validatebp.org, where it actually lists some devices which have been shown to give good blood pressure numbers. You can do those at your home. You need to learn how to do them correctly. And I know Target BP actually has videos on how to appropriately measure a person's blood pressure at home. And then if you have a really great provider, you may be able to bring those into the meeting, whether it be virtual or in person, and discuss whether or not your blood pressure has been adequately controlled. This idea that Mrs. Brown goes to the clinic and some doctor spends that magic 15 minutes and tell her your blood pressure is all right, and then she goes home and not knowing the number, I think is adverse to having the optimal outcome, because many times all right is code for you got high blood pressure, but you're an old Black lady and that's what your blood pressure is. See you in 3 months.
Yeah, I think that definitely is important. And, so I just want to say it again, bp.org is what you're recommending as a place for people to go to be able to get devices that can help them adequately monitor.
Targetbp.org.
Target BP, thank you.
TARGETBP.org.
Okay, that's good to know. And then I mentioned earlier on the American Medical Association and what they're doing. They also have a program that they're sponsoring called Release the Pressure. And that program is really meant to help people engage in just what you described, Dr. Ferdinand, really understanding their blood pressure numbers, being mindful of it, helping them better navigate conversations with their healthcare providers around hypertension and how to adequately control that. And, it's a great approach that they're taking to make sure that program is available and that patients, people who have hypertension can really rally and find resources within their own communities to be able to help with that. So Release the Pressure is a really powerful program that we feel can have a really positive impact on that. And I know that a lot of how they're targeting it is through Black women, because we know Black women often are the caregivers for their families, for themselves. And really having them be a catalyst for change around this is important. Anything to add to that, Dr. Ferdinand, in terms of how we can leverage those of us in our families, the Black women in our families, to help with that, and making sure that they're having proactive conversations with healthcare professionals around the improvement in their hypertension numbers?
Yeah, certainly the psychosocial stress, the built environment, the social determinants of health, structural racism all play a part. But we still have to treat blood pressure and treat it intensively. There have been multiple studies to show that the old 140/9 just is not good enough. And that's why the blood pressure goal was lowered to less than 130/80. The antihypertensive medications can be given safely and effectively, along with modifying lifestyle, low sodium diet, increasing potassium, physical exercise, weight maintenance or weight loss, and of course, mindfulness, meditation, seeking mental health if you need to. There are lots of things you need to do, but we can't just wish this away. If you go into the data on dialysis, 35% of people who are on dialysis are self-identified Black. We're about 13% of the population. It's 3 times more than we predicted on a population basis. If you look at heart failure hospitalizations and deaths are higher in Blacks. And specifically for Black women, the life expectancy for Black women is more similar to that of a white male and much shorter than that of white women because of hypertension and cardiovascular disease. Bad TV shows and B movies talk about drive-by shooting and drug abuse. White kids use as much drugs as anybody else. Yes, we do have perhaps more violence in certain communities, but that's not why we have the white-Black death gap. It's driven primarily by cardiovascular disease, and hypertension is the most prevalent and potent risk factor.
Okay. All right. One of the other things too, because we talked about 2 aspects of this, the medical community, what is the medical community doing? We've had some panelists on previously with conversations, and those physicians were saying that medical students are starting to demand that they understand more about cultural competency and how to engage with patients in underserved communities and patients of color. So do you feel like medical organizations and medical schools are starting to lean in to help healthcare providers better interact with and care for patients who may not look like them?
I'd like to say that cultural competency isn't enough, because what we hear here is that it's not just individual biology that creates ill health, that there are all these structural factors. And I think that medical institutions are going to have to go a little bit further, whether it's through structural competence, some of the work by John Metzel and Helena Hansen, about really looking at the structural contributors, we call them social determinants of health, but even look at, social medicine, the institution that I'm associated with at Charles Drew University. Social justice is part of the mission of medical education, and looking at these other factors, the economic factors, the social factors that influence health, and not just thinking that it's individual bad behaviors that create ill health. So I think we're going to have to go much further than implicit bias and cultural competence. We're going to have to see medicine as part of a structure of racism that needs to be untangled.
I'll also offer, I know here at Einstein, they are embracing more teaching around structural racism and trying to create physicians who are more aware of some of these things. But part of it, I think, is also acknowledging each person has to acknowledge where their racism lies, right? Like each person has to do the work. And it's a commitment for life to be anti-racist. It's not just, I took this class and I felt uncomfortable for 15 minutes and now I know what it's like, it's a commitment to learning and unlearning behaviors and assumptions about people and expectations that we have for the health of certain populations. But then it's also advocacy. So, I took a lot of inspiration from Tamika Mallory when she said, when Philando Castile was killed in an AutoZone parking lot, where was AutoZone saying, we don't like it when police kill unarmed people. We want to talk to the police who are killing unarmed people in our parking lot, right? When we recognize that no-knock warrants killed Breonna Taylor and that Black people are reeling from really such, dehumanizing conditions, why not? Why wouldn't a medical school call the police department and say, we want to get rid of no-knock warrants? It's killing our Black patients. So those are some of the questions that are starting to come up these days in some of our circles. Like, just how can we reimagine all of this so that we can just, release the pressure? Maybe we can really make some major changes in how we function as doctors.
Yeah. And I got a question here too that I want to just pose to the panel. Someone asked, what are the most important things we can do or that can be done to combat the structural racism and or the adverse effects of structural racism on health?
Well, I think you should support initiatives, candidates, and programs that access universal health care for everyone. And we need to make sure that those programs are funded and that patients have available sources of care. In the school lunch program, I've been around long enough when I remember that there was an effort to improve the sodium load and the saturated fat in school lunches, and that was overturned recently. Go to the website of the USDA and you'll see it yourself, where they say we're going to make school lunches great again, meaning that they were going to put the salt and the fat back in. The government services about 60% of the food in the United States when you take into account the school lunch programs, the military, the prison, and the food commodities given in disadvantaged communities. So the government can have a great impact on high sodium, high fat foods that are being served to the American people. We know that there's a lot of money being made off of Black misery, selling tobacco, cigarettes, highly processed foods, and we need to understand that and reverse some of those findings.
Okay. Dr. Glover, Dr. Serbinson, anything to add there?
I think as organized medicine, we really do have to advocate at the highest levels in public health spheres and public health conversations, but also recognize that public health is not just the health department, it's not just the AMA, it's also reaching across to the other organizations. So for example, the American Psychiatric Association recognized that people with mental health disorders were ending up in prison when they really needed treatment. So then they started educating the judges about the nature of mental illness so that the judges would hopefully look past their own biases against Black people and people who were more likely to be incarcerated, so that they could help direct those folks to the mental health services that they deserve. So the idea is like, let's think outside the box. If we recognize that when terrible things happen to innocent Black people, or when Black people are not being treated as fully human, let's talk to the people who are initiating the bad treatment. And let's make sure that they know that we're watching. I think that's one of the things that goes a long way, is just letting our society know that we're watching and we're willing to take action.
Well, there certainly are a lot more conversations. Go ahead, Dr. Serbinson.
No, I was just going to add that, the history so far has been that it's Black doctors who've had to take care of Black people for the most part. And I think we are going to have to re-engage our commitment to seeing ourselves as really healers in our communities. So there's the things we do in our regular practices that's part of the job, but we can be much more like we used to be, engaged in our communities, doing some of the messaging that we hear from Dr. Ferdinand and hopefully myself and Dr. Glover. We have to be out there because, again, what we learned in New Orleans, no one came to save us. We had to turn up for ourselves and figure it out. So until the other side gets their act together as Black, somewhat privileged, socioeconomically privileged people, we need to feel more responsibility to care for those in our communities who have lesser access. We need to insist that resources need to follow need, not privilege.
But I also offer, I would love it if all of the clinicians on here today, if they're concerned about the cardiovascular health of their Black female patients, connect them with culturally appropriate organizations. So there's Girl Trek, right? We talked about the benefits of cardiovascular activities, physical activities. So girltrek.org is a wonderful organization supporting the health of Black women nationwide to get Black women walking, to help them meet each other so that they can walk together safely. Because, right, I think for women, I don't like, I mean, the day the sun goes down at like 2 p.m. here in New York, you know, it's dark as midnight by 4 p.m. So the idea is like, why not help connect to other women who are taking control of their health as well? Let's get outside, let's take a walk in a safe way where we're not alone and along a path that's familiar to us. And hopefully by having that accountability partner who's also of the same culture, I already feel like I'm arriving in a place and doing an activity that feels right and that feels like home.
Mm-hmm. That's definitely critical. And, you know, going back to what we've been talking about, there's a lot of work to be done on kind of the structural side and the medical community side. And it's nice to see if there are kind of glimmers of hope in those areas, but there's also things that we can do too. So, you know, to your point, like how can we mobilize as a community, as and advocates and allies within our own groups to help with that? And, you know, I just want to say again, with the Release the Pressure campaign that the American Medical Association is sponsoring, I think that's really important as well. And, you know, for if anybody who's watching wants to know more about that, you can enter your email in the form found in the comment section of this particular session. So it'll be there and the AMA will send some follow-up information. And again, kind of the elements of the Release the Pressure campaign include knowing your numbers, measuring and understanding your numbers, making a plan with your healthcare provider. Dr. Ferdinand talked a lot about why that's important, and getting a squad together to really help support that. So it's releasethepressure.org, and take the pledge to be part of a community that's committed to positively impacting the rates that we're seeing of uncontrolled hypertension. So I know that we just have a few more minutes. I'm going to check and see if we have any questions, and then I want to see if there's anything else parting that you would like to share. Yeah, no more questions right now. So anything else? I think this has been a great discussion. Lots of work to do, but you know, we at Black Health Now always want to think that there are things that we can do. And you know, one of the things that I've been heartened by, I'm cautiously optimistic, is, you know, based on everything that's been happening this year, COVID, a lot of the social justice things that we've seen movements around, I feel like it's kind of bellwether in a sense that people are recognizing the inequities, the disparities, the structural racism, the institutional racism, and also from a community perspective, they're recognizing more the need for self-care, right? Whether that be going for the walks that Dr. Ferdinand talked about, making sure that you have a plan for hypertension, whether it be about other aspects of self-care. So I'm hopeful that maybe these kinds of conversations and having professionals like yourself really lean into this, and the American Medical Association, maybe there will be some change. And I'd love your thoughts on that.
Well, I'll go first. I think my parting message is that everyone should know their numbers. Don't be a passive participant in your own health. Get a blood pressure cuff, monitor your blood pressure, challenge your physician as to why your blood pressure numbers aren't where they need to be. If someone sticks you and draws your blood, get the results. Don't let someone tell you it's all right. What's the number? What was my glucose? How were my kidneys? What was my cholesterol? Was the LDL elevated? And then take that information and make appropriate changes in your own lifestyle. If pharmacotherapy or drug therapy is recommended, adhere to it. If you have problems with the medicines, then change, get other medicines. But we've already done the placebo-controlled trials where we have patients with hypertension and we just kind of watch and see what happens. What happens? Strokes, heart attacks, heart failure, chronic kidney disease, and death.
Okay.
And I guess I'll go next. I really actually want to underscore something Dr. Glover said, in addition to everything else that has been said so eloquently by Dr. Ferdinand. But this idea of mindfulness, it's an ancient Buddhist practice. It is a way of being, it's not something you have to do. And I find for many of us as African Americans, part of our coping has been to ignore and keep it moving and not be present in what our reality is. And one of the best ways to find equanimity and peace of mind is presence, knowing exactly what's happening in your mind in the moment and what's the sensations you're having in your body. Because by mindfulness, and I guess for disclosure, I have the best doctor in the world ever, and he's right here, Dr. Ferdinand. And it's been his amazing support, plus my realization I had to be present in my body because I had that really bad hypertension, and I had to totally change the way I put myself in living my life. So I guess I would just say, make mindfulness a practice, do all the things for physical body, be in touch with what that body feels like. And I think we'll continue to make it through.
Okay.
I love that. I love that.
I love it too. I love it too.
I think the only other thing that I would add is I see in the questions people are asking, like, what more can we do? We want to add more, we want to do more. I think I appreciate this commitment to learning. I think reading, I think all of us are in this period where there's all these new books coming out about how to just be a better human being, how to treat people who we consider marginalized or minorities better, how to be anti-racist. I think Adrienne Marie Brown's book, Pleasure Activism, I think is very deeply meaningful. I think the way women, particularly Black women, are socialized here in the United States, it's all about taking care of other people and ignoring some of the most basic ways that one should take care of oneself. So I think we're really undergoing a major shift in how we're functioning. And I think mindfulness is that key that kind of unlocks that door to tell us, like, wait, I don't even like the way this chair feels. Why am I sitting here? Or I didn't realize I've had to go to the bathroom for the past 2 hours, but I was taking care of all these patients, so I didn't pay attention to that. And so recognizing that as women, often we're socialized to ignore so much of that. And yet those are the things that are at the core of our well-being.
Mm-hmm. So speaking at the core, there's another question here around mindfulness. Like, in embracing that, how do you process the negative and rage-filled emotions that arise?
To me, that's why blues music even exists. That's why brown liquor exists, right? Like, that somewhere between all these cultural, like, wonderful traditions we've inherited, I think that's why dance exists, right? There's this wonderful research. If you listen to Brene Brown's podcast, she had these 2 researchers on who looked at ways to sort of complete this stress circuit, right? You are undergoing lots of stress in your life. You're dealing with COVID and loved ones and navigating traffic and alternate side of the street parking rules and menstruation and whatever. And then you recognize, oh my God, my heart's racing or my blood pressure is high. Okay, so you go to the gym or you take your walk. But the other piece that you need is joy. You need to actually get more serotonin coursing through your body in order to just sort of complete that stress circuit. So maybe it's time for us to connect with loved ones, either over Zoom or in person, and get and laugh together and dance together. Again, even if it's remote, because it's a pandemic, right? So we have to be careful, but you have to complete the circuit with some joy.
I love that. Complete the circuit with some joy. I think that that's an amazing point to end on. Dr. Ferdinand, Dr. Glover, Dr. Serbinson, I am absolutely thrilled that you all were able to join us. This was an important discussion, and from the questions, folks that were watching were truly engaged in this. Lots of good information shared, and I appreciate it. So everyone, again, this is Black Health Now. Thank you so much for joining us for this session, and we will see you next time.
Thank you.
Thank you.
Thank you.